have known that last week we had to do a little bit of rescheduling because Shannon had a little bit of an accident. So we talked about that a few minutes ago, and she is fine, thankfully. We were all concerned about you, and everyone wished you well. So Shannon Garrett is a thyroid recovery nurse specialist and certified functional nurse nutritionist. She's also a Hashimoto's patient and went through an 8-year journey of being misdiagnosed over and over again by a long list of doctors, which this is a common thing that we hear with people with thyroid problems. She's also the creator of Hashi's Sisters, an autoimmune thyroid home study course for women, and the website Holistic Thyroid Care. She has dedicated her life to helping women overcome Hashimoto's and secondary autoimmune conditions. She believes you can reverse the symptoms of Hashimoto's, feel amazing, and enjoy life again. I believe that too. I believe that too. And so many people have lost their hope in that. So I'm happy to see that you believe that as well. So I'm gonna have you share the information about the LDN, because it is in my thyroid guide as one of those useful tools that people should be looking into if they have been diagnosed with Hashimoto's. So why don't you go ahead and talk about that? Why don't we start out there?
Start off with LDN?
Yes.
Okay. Well, thanks, Carmen, for having me. I always love the opportunity to speak about Hashimoto's, women's health, and particularly low-dose naltrexone. So LDN, low-dose naltrexone, is it's an immune system modulator. So it can help people get into remission from most autoimmune conditions, including Hashimoto's. Now, it's not a first-line defense. I never recommend it as your first option because some people are able to get into remission depending on how early they were diagnosed. It's really indicated for those who, have been on their journey a really long time. They're following all of the protocols. They're just not really getting in any better. But it's not for everybody. There are situations LDN will not work. Fortunately, it's getting greater coverage and more people are learning about it. More doctors are learning about it. Still yet at the conferences, it's, on LDN, it's really only discussed in terms of how to treat every other autoimmune condition besides Hashimoto's. And where LDN and Hashimoto's are concerned, as they relate to one another, the treatment protocols are different. Getting the body ready for LDN is different. So there are a lot of variables there. Having said that, being misdiagnosed myself for 8 years by 9 doctors, and when I went through my misdiagnoses, that was when Facebook didn't even exist, if we can remember that period of time.
Very far back. No.
There were no outreach. There was no way to really connect with anyone. So when you think about, a decade that I went, misdiagnosed, damage to my thyroid going on almost 10 years. By the time I was diagnosed, knew what to do, followed all the protocols, there had been just too much damage, to my thyroid to expect the integrative and functional medicine protocols to really help me. So LDN was a lifesaver for me.
Yeah, we run very parallel stories with that because my story is very similar to yours, where I went a decade without anyone telling me what was wrong, and I went to 21 doctors total before someone finally said, I know, isn't that crazy? And I have some experience with LDN. So it is one of those things that I had to get extremely educated on and take to my doctor because they weren't even aware of what it was or what it could do for me. So let's talk a little bit about why is Hashimoto's the one autoimmune disease, since it's one of the most common autoimmune diseases in the country, right? Mm-hmm. Why is it not being looked at for this particular therapy?
Well, I think that it's just discounted in the mainstream medicine, really, for the most part. When you walk in the door and you're diagnosed with any other autoimmune condition besides Hashimoto's, you're immediately prescribed an autoimmune suppressant, which I don't advocate for that. However, when you're diagnosed with Hashimoto's, you're just given thyroid hormone and sent on your way. So if their analogy, held water, that we need to address the immune system, then why don't they do that with Hashimoto's? I think their thinking is that the thyroid will just burn itself out and will continue to give replacement thyroid hormone. They're not making the connection that the immune system will continue to find other targets. And
Right.
this is how women end up with 8, 9, or 10, these multiple autoimmune conditions.
Yes. Yes. And so in other words, it doesn't this kind of follow the theme that people with thyroid problems tend to run into when they go to the doctor is, well, just take this pill and, that'll take the place of what you can't do on your own. They don't look underneath the thyroid. They don't look for the problem that's causing this in the first place. They just give you a pill and send you on your way.
Well, and two, and I can see where certain situations can happen for a woman. So, and I'm not defending doctors in any way in this regard, but consider that you're a physician and you're in practice and 50 women are coming in to see you in and out the door all day long, and they're all saying, I feel fatigued, I'm so tired, I'm gaining weight, so forth and so on. That sounds a lot like depression at the end of the day, or anxiety.
Right.
And they just don't delve deep enough into what's really going on. And plus they're training, depending on where they went to medical school, they're trained to test TSH and T4, and that's about it.
Right.
And if they do give replacement thyroid hormone, it's usually Synthroid, and it's just not on their radar. They're seeing multiple issues, diabetes, hypertension, all these things, and it's just not their focus. I mean, the best doctors, nurses, practitioners across the board who work with the Hashimoto's patient population are those who only work on that specific discipline.
Right. So let's talk a little bit about, because we talked about thyroid, the thyroid gland, the endocrine system, all of those things, but we haven't spent a whole lot of time on Hashimoto's, the autoimmune condition itself. So can you talk a little bit, let's do some layman terms explanation of what is Hashimoto's and why are so many people being diagnosed, or why, and also, why is the diagnosis being missed?
Yeah, so you have some doctors who don't believe Hashimoto's can be healed, so they're just viewing it as hypothyroidism. Hashimoto's, hypothyroidism, two completely different conditions. However, hypothyroidism is going to be the result when you have Hashimoto's.
Right.
So with Hashimoto's, your body has basically, it can no longer tolerate itself. You've lost self-tolerance. Okay.
Mm-hmm.
And the immune system starts to attack the thyroid cells. The thing with this, Carmen, is that this is probably going to shock your students. I know it shocked me when I learned it a couple of years ago. In the diagnosis of Hashimoto's is typically made when on a lab test, those TPO, something called thyroperoxidase antibodies, show up. However, the absence of those antibodies doesn't mean you don't have Hashimoto's, and the presence of them doesn't mean you do. The only way to definitively know if you have Hashimoto's is to have a thyroid removed and the tissues excised. Well, nobody's going to do that, okay? You can donate your thyroid at your autopsy and find out or whatever, but we just have to assume that if someone is hypothyroid, even though those antibodies are not present, we still need to assume that they have Hashimoto's, because Hashimoto's is, accounts for 95% of hypothyroidism cases. But it can take 15 years for the antibodies to show up. Okay, so this is how many women are going along their path, and maybe they have been diagnosed with hypothyroidism, but they've been told, well, I don't have Hashimoto's, so I don't have to worry about healing the gut, the adrenals, and all the things that are in concert with healing Hashimoto's.
Right. So
that's unfortunate because it's just where people in mainstream medicine don't have an understanding that it can take a long time for those antibodies to show up. They can also show up for other reasons other than attacking the thyroid.
Okay, let's stay on that for a minute, because we did talk about false negatives in one of our classes the other day.
Mm-hmm.
How people who say that they can eat gluten if they want to because they are negative for Hashimoto's. And I actually got my dad's labs the other day and said to him, I've been watching your thyroid and I'm telling you there's something going on here.
Yeah.
And he's like, but my thyroid antibodies are negative. My doctor told me, and I said, well, we'll talk when you come home for Christmas. So that is something that we've talked about. But what I have not heard before in too much detail, just touching on it slightly, is that your antibodies can be elevated when it's not Hashimoto's.
Right.
Yeah. So I've heard that, but I never really paid much attention to it because I have Hashimoto. So I've never really invested much thought into that. Yeah. So talk a little bit about that.
So they can be elevated in rheumatoid arthritis. They can be elevated in lupus. They can be elevated really for not reasons we don't understand yet.
Okay.
Any inflammatory process that's going on in the body, thyroperoxidase can get activated and appear. Really? Mm-hmm.
Okay. So does that go hand in hand with an ANA test or maybe an ESR test or another inflammatory test?
Possibly, but a lot of times the ANA and CYP rate may not be elevated.
Yeah.
There are various liver issues that TPO antibodies can appear. It's really interesting. But when you see a patient hypothyroid and those antibodies are appearing, and particularly when they continue to climb, we can confidently say we're dealing with Hashimoto's.
Okay. And how does the TSH and the free T3 and free T4 play into that? Do you look at those numbers as well when you're looking at TPO and say, okay, the TSH is rising, the other numbers are lower than they should be,
yes.
maybe reverse T3 is high? Is that more you lean towards that TPO as being a Hashimoto's diagnosis? Is that right?
Well, using your clinical judgment in concert with the other labs, yes. You can't just look at one in isolation, really.
Right.
You have to look at, there are conversion issues to consider, like is this patient on thyroid medicine or are they not? Is it in their endogenous, the thyroid hormone that their own body makes? Are they converting their own thyroid hormone? Are they converting thyroid medication? How does free T4 and free T3 rank in concert to one another? You know what I mean?
Yes.
You have to look at that. Reverse T3 is an interesting marker, and it's very misunderstood. It's not really a bad thing to have. It's the way the body protects itself from converting too much T4 into T3. There can be excessive levels of that number, however. The main thinking, or the main belief, I think, is what I read on Facebook anyway, is that the thinking is that if you have too much reverse T3, it's because you need, let's see, what do they say, T3 only medication to clear it. And that may not be the case at all. What I see in most cases of elevated reverse T3 is a woman who's trying to starve herself to lose weight, and that will trigger a rise in reverse T3.
It's interesting you say that. I've done that T3 only protocol many years ago. It was one of the things when my reverse T3 was excessively high, and I didn't have an in-depth understanding that reverse T3 rises when you're stressed out. It's putting the brakes on the energy, right?
Yeah.
I had no idea. And so I start looking into this. Why is this happening? What's going on here? And then, as a person without anyone here guiding me, learning this all on my own, I have someone giving me medication, but not really knowing what to do with me. I went ahead and tried that route of the T3 only. I didn't really see much benefit from it, but it was worth the guinea pig, making myself the guinea pig to try it and see what I thought of it.
Yeah.
But then I've also been told that no one should only take T4. Like no one should only take T4. I actually feel better taking only T4 lately in the last 6 months than I felt good taking both of them. Isn't that interesting?
That is interesting. Which, I don't know what to say to that, because it's the same with, for example, vitamin D. In the hospital setting, they always give vitamin D2 to patients who are deficient. And that has to be converted to D3. So it's the same with thyroid hormone.
Right.
we can't use T4 at all, really. It's not the active hormone. It has to convert to T3. So you're apparently an optimal converter, maybe.
Yeah, let's talk about that. Let's talk about the conversion part. So, my understanding, you tell me if I'm wrong, is that most of the conversion happens in the gut and the liver. Is that correct?
That's correct.
Okay. And what about the other parts of the body that, where else is it prevalent for conversion?
In the peripheral tissues, not as much, but mostly in the liver and the gut. And so you need cofactors to help with the conversion, like zinc and ferritin. Those are key cofactors for the conversion. Vitamin D, if a person's vitamin D level is low, they're not going to convert. It's not that they won't convert the thyroid hormone, it's that their cells can't receive it. Because it's vitamin D is actually not a vitamin at all, it's a hormone. And one of its functions as a hormone is that it makes the receptors, those little windows on the cells, T3 receptors, to receive thyroid hormone. So if you're low in D, you're low in receptors, and you may have thyroid levels that are elevated in the bloodstream, but it's not getting inside the cell. And we have seen patients where that's the case, where they're on higher and higher doses of their thyroid hormone, but they're still presenting with these, significant hypothyroid symptoms. And we know that, there's a conversion issue, there may be a D3 issue, something's going on, it's not getting in the cell.
Right. So it's almost like the cells they're not sensitive to the hormone, or they're blocked somehow. Is that correct?
Well, it's like, think of a cell as your house, and you have windows. It's just in the windows are the receptors. Right. So if you don't have as many receptors on your cells, many windows, the thyroid hormone can't get in, and that's where it needs to go. Okay. So let's talk about how do you approach someone who comes to you and they've been diagnosed with Hashimoto's? They've probably been through the same types of things you and I have been through. And let's say that they've had an ultrasound done on their thyroid, and which I thought was fascinating, what you said about having the only way to definitively say that you have it is to take it out and biopsy the thyroid. Right. Is it ultrasound not at all? I mean, I know it's helpful, but is it not indicative when you see the marbleization on a thyroid that you can say that's Hashimoto's? Well, really, with an ultrasound, you're mainly seeing if there's nodules or not. Right. Or it's assessing its size and if there are nodes and if the nodes are growing. It's a great assessment for that and for thyroid cancer, but it doesn't necessarily tell you if they have Hashimoto's. Okay. I did a blog last week, and I'll just mention this, is that thyroid cancer is the fastest growing cancer in the United States and has been since around 1990. And it's crazy because Hashimoto's and Graves' disease or any autoimmune condition actually predisposes you to being at higher risk for cancer. So Hashi's and Graves' patients have a higher rate of thyroid cancer. Well, in the United States, we're advocates for, let's get our breasts examined every October or our birthday, and let's do the colonoscopies and all these things. But we're not doing any prevention, wellness screenings for the thyroid. So as low cost as a thyroid ultrasound is, I'm really starting to advocate and speak out more that, ladies, we need to be asking our doctor for a thyroid ultrasound every year or every other year if it's normal, and every year if we have a nodule. Yeah, I get one every year. And the first year that I got it, I was talking to the coaches the other day that when we have clients that may, come to us and say, I got a thyroid ultrasound and it came back with, multiple nodules. It can instill that fear and panic in them. I remember getting mine, and I'm that person that's always like, I would like a copy of the disc, please. I would like to get this emailed to me, please. Yes. And I brought it home and I put it into my computer, and I was able to view it at the time. I didn't have a Mac, but and I was reading the reports, and it said, multinodular lobe number 2 or something, and then it was giving specifics, and I'm sitting there like oh my gosh, thinking I'm dying or something, because the word nodule can be scary. Sure. But it also said ultrasound indicative of Hashimoto's thyroid disease on the notes.
And so that was kind of the confirmation, right? I thought, well, there it is. Interestingly enough, I went out there, I got off gluten, I got off soy. I was like, I will be darned if this is going to be my, death sentence. And when I rechecked it the following year and the following year, there had been no more growth or change.
Awesome.
But I think, so tell me, is that something that when people come to you and they've been told they have nodules on their thyroid and they're living the standard American life, right?
Yeah.
How do you get them to understand how important, what they put in their mouths is, how they're living their life is? How do you go about that part?
Well, I teach every woman, I only work with women, that there are 3 factors. First of all, they need to understand there's 3 factors that brought you here to having Hashimoto's. One is a genetic propensity, not that your parents or anyone in your family had Hashimoto's, but they may have had another autoimmune condition. Grandparents may have. So genetic propensity, intestinal permeability, which is leaky gut syndrome, and a trigger. So the trigger could have been a virus, a bacterial infection. It could have been overwhelming stress. It could have been heavy metals, just some trigger. You're going along in life and you're fine, so to speak, you're functioning well. But something put your body over its tipping point and you lost self-tolerance. It lost self-tolerance that I mentioned earlier. And to me, Carmen, regardless really of the label we put on all the 100 autoimmune conditions, they're all the same thing. It's just that they're attacking different tissues, in different people. But what I try to have women see is that there is something, it's not anything they did, but there is something in their background that triggered, this problem. So definitely we look at the gut, we look at the adrenals, we look at the sex hormones, we look at the diet, we look at everything, stress, what do they do in their daily life? I get asked a lot, though, don't I need to start with the gut first? Everybody's heard, don't we heal the gut first? Well, not necessarily.
Right.
What I see usually is that we need to heal the adrenals first. If cortisol is out of balance, you're not going to heal the gut no matter what you do. I mean, obviously you want to start eating better, avoid those foods that play a role in molecular mimicry like, gluten, soy, GMO corn, dairy, and such. But you still need to really, depending on what phase of adrenal fatigue you might be in, that really has to be a goal, because with the best efforts within healing the adrenals, it takes on average 9 months to accomplish that.
Yeah, that is one of the things that I think is kind of flip-flopped when you go out into some of these Facebook groups and you're reading people who are advising people on what to do about this problem. All you're hearing is, oh, well, heal the gut. You can't do anything without it. And I agree with you 100% that, the very first thing for me in feeling better with my thyroid has always been getting any cortisol issues, any stress under control, and feeding my adrenals before I actually feed my thyroid. In fact, I've gone off medication before to take care of my thyroid or my adrenals first because it was too stimulating for me. The energy that was putting out, right?
So thyroid hormone definitely can. A lot of women will believe that they're hypothyroid. They know they have Hashimoto's, but in terms of the hypothyroidism side of it, they feel that medication will, bring them back to life, when in reality it may make things worse because the adrenals can perceive that medication as a stimulant. Yes. And one way you can test that is with what we call orthostatic vitals. So you can sit in a chair, have someone take your blood pressure, take that reading, immediately stand up, take another blood pressure reading, and if the systolic, that top number, drops, your adrenals are stressed. So that's a good piece of objective data to share with your doctor.
Yeah. Okay. So so let me be clear, because I know my students, and I know when they start hearing this, they're going to be like, okay, I want to know, what did she say about that? How do you do that? So you take it when you're seated and you get a reading, and then you stand up and you take it again while you're standing. So you don't stand up while it's on, you take it sitting and standing, 2 different readings. Okay.
But immediately.
Immediately, yes. Because of course we know it changes if you breathe or the wind blows, your blood pressure changes, right?
Well, I mean, and it should go up from sitting to standing. But adrenal fatigue, or if your adrenals are stressed by thyroid hormone, it will drop.
Right, right. Because movement is a stressor, right?
Right. And the adrenals can't push the epinephrine fast enough for you to rise. So it will drop, and then there you go.
Yeah, interesting. So do you also agree with the pupil test, the pupil dilation dark test?
Not really. I mean, I don't really rely on that much. I tend to rely on numbers.
Yeah.
Not lab obsessed or anything like that, but just good objective data. There can be a variety of reasons in pupillary changes, not necessarily adrenal or thyroid related.
Okay. Okay. Yeah, that makes sense. So we have a question from Andrea. She says, so once you have nodules and make necessary diet and lifestyle changes, you can prevent new nodules, but you can't get rid of nodules you already have. Is that correct?
I have not seen nodules disappear. So correct. I have seen them shrink.
Okay. So never gone away.
I have never seen that. Never say never, but I have not seen them disappear 100%. But I have seen them become inactive. You can have hot or cold nodules, so active or inactive. And I've seen them shrink in size and be inactive. So that in that case, you definitely want to have an ultrasound every year.
Mm-hmm. Yeah. Yep. Okay. So I want to circle back to LDN, because even though it's in the thyroid guide, we didn't talk about it in detail because it's such a kind of a new thing, and there was enough in the guide to get them started on the learning part. So let's talk a little bit about how it actually works. What's the mechanics of it all? When someone let's talk about how the opioid receptors, and I also really want you to touch on a little bit about the stigma that's around naltrexone, because it's used for addiction, but it's not used for addiction in this particular case.
Right.
So talk about that a little bit.
Okay, so just speaking to naltrexone itself and its 50 milligram dose, it's been around since the 70s or just prior. Mm-hmm. And as you said, has been used for opiate and alcohol dependency. So they learned, Dr. Bahari is credited for some of his research in discovering that you can modulate the immune system when it's compounded in low doses. He worked with patients, HIV/AIDS cases, and found this to happen. And then some other researchers carried on his research after he passed away, but the drug companies never picked it up because it's been in generic form for decades. So the patent had expired many years ago, and there's no money to be made off of it.
Right.
But the way low-dose naltrexone works is that it closes the opiate receptors on our cells. So we're born with opiate receptors, and this is one reason why opiates can be so addictive for people, is because we were made with those receptors. So it blocks those receptors, and it's thought to work this way. If you shut off your opiate receptors, your body wants to produce more endorphins, which are natural opiates. So it sort of tricks the body into healing itself. It happens while we sleep. Our opiate receptors are turned off, and the immune system releases all these endorphins, which leads to the most common side effect of LDN during the first 2 weeks, and that's sleep issues. It's not that a person's not sleeping. They are sleeping. It's just they're waking up multiple times during the night because of the endorphin release. But that sort of balances itself out. And this is what is thought to regulate the immune system, to rein in those overactive antibodies and the fire that's actually been, churning in the immune system. Because it's not just TPO antibodies causing inflammation, it's the leukocytes. It's all those white blood cells that have become confused. Where there is a stigma associated with LDN, and there is, and this is why I myself don't even share that I am on LDN with doctors who don't necessarily need to know.
Right.
Because, for example, if you reveal this information to, for example, I went to an orthopedic doctor last year, and I did, share it with the front office desk. That big mistake. Low dose naltrexone, LDN, is not going to be in their database, to choose from as a medication. Right. But naltrexone is.
Yes, yes.
And that's what they will put in your chart. And then they're going to assume you have a drug or alcohol problem.
That happened to me too. That happened to me too. I'm like, low dose naltrexone. She was like,
no, it's not.
No, we don't have that. I'm like, then just don't write it down. Spare me, okay?
I didn't say that. Just ignore what I said or whatever. It is crazy that has to happen. Now, I will say it is important for a family member or someone. We don't have bracelets yet. I think we should.
Mm-hmm.
If you're in a car wreck,
yes.
If you're on LDN and you're admitted to the hospital. Now, here's what is confusing to a lot of people, a lot of misinformation. If you have to have surgery, your anesthesia is going to work regardless. A lot of people think your anesthesia won't work if you're on LDN, and that's not true. It is going to work. That's not an opiate drug. What won't work is post-op pain medications. So they need to know, that you're on LDN so they can administer the correct pain medication. If you're having an elective surgery, you go off LDN like 2 weeks prior, and you're fine.
Yep, that's what I do with my hernia. I remember all of that. Everything you're saying, I remember that. And but interestingly enough, I want to know if you can share how it works on dreams, why the nightmares were so horrible for the first 3 nights. It was like being in the Friday the 13th movie.
Well, that's the endorphins. That's the trigger of the endorphins. Your brain's sort of stimulated, so to speak. But for me, I didn't have nightmares. I just have and I still have the most vivid, colorful, hilarious dreams, just crazy dreams, like my poodle's flying around holding umbrellas or whatever. I mean, I have crazy, colorful dreams. I
have those anyway. I can fall asleep for like a matter of seconds, and an entire year would have passed in my dream. It's bizarre. And my husband never remembers his. So I think it was amplified when I took LDN. It just really, the scariest dreams I've ever had in my life. Like, it woke me up like sweating and had to turn lights on, thought someone was in my room. Scary.
Oh my.
I know. And that's one of the reasons I was hesitant. I went off of it for the surgery, and I was like, I don't want to go through that again. But I got back on it, and it happened again the 3 times I've gone off. So I thought that was really interesting.
That is interesting. So when a patient's wanting to go on LDN, as I said earlier, I never recommend it as a first effort ever.
Right.
We've got to get all the other issues in place. So nutrition protocols, stable and thyroid hormone, address nutrient deficiencies, heal the adrenals, balance the hormones, heal the gut, and deal with stress, and try to figure out how to take care of ourselves and still exercise every day and stuff without over-exercising. So all that has to, it all works together. LDN is not a standalone treatment. And even for myself, it took me 9 months to get my body ready for it, because I wanted to give LDN the best opportunity to work. I met with resistance a lot with some women I work with who were like, I want to go on it now. I don't want to have to change everything else.
Yeah.
But it won't work.
Yeah, it won't work if you don't.
And LDN can stop working too. So I had a patient last year who, she'd had great success with LDN. And then just all of a sudden, it's not working anymore. And we looked and we ran some labs, and she had a reactivated Epstein-Barr virus.
Ah, really?
Mm-hmm. And it was overwhelming her system. So we had to treat that. And then once that was cleared up, she went back on LDN and was fine.
Okay. So that, I keep talking about myself, but all of this is relatable because I've had these experiences. Everything you're talking about is just right on the money. I mean, it's the hammer on the nail, because I had strep throat about 4 years ago. And I think I told you this when we were talking, that I had 104-degree temperature. And I could not, the strep, I didn't have a sore throat for more than 24 hours, but I could not shake a fever for 8 days of 104. And so I went off of the LD. I went and got tested for mono, all of that. I went off of the LDN because I couldn't think of any other thing that could be keeping this going. The fever was gone within hours.
Wow.
So it must have been, I mean, if we think back to where strep throat comes from, it can be, or is tied into viral, Epstein-Barr virus as a flare-up. Very interesting that you said that. Yeah.
Yeah, and Candida, for one, Candida is brought forward, or let me back up. LDN can bring Candida forward. So this is why we want patients who want to go on LDN to really get a handle, on the fact that you're probably going to have Candida protocols around all the time. And the reason it brings it forward is because Candida is a natural part of the immune system. So, we're supposed to have it in certain ratios. So as LDN's modulating the immune system, if there's already just a hair of an overgrowth, it can get really excited and get ramped up. That's just an unintended consequence. So, and if that does happen, Candida will block LDN from working.
Okay. So talk about the Candida protocols that you believe in. What do you believe is the best? Because there's several out there. And what have you seen the most success with?
Well, first of all, we want to go through an anti-Candida diet. We like to look at food sensitivities and then go through a Candida diet. Because all the pills we take in the world for Candida aren't going to do any good if we're eating sugar and, and junk and stuff that's causing inflammation for our unique body. I really am a huge fan of grapefruit seed extract. That's real easy to implement. It comes in capsules or tablets and then oral liquid. The capsules or tablets, they change that all the time. It's either in capsules or tablets whenever, whatever's on the shelf. By Nutribiotic is the brand that I like. But that will kill everything below the esophagus down. The liquid drops will kill anything in the esophagus and up, like what's in the mouth. So it's really a great product. So is Candex, that's over the counter. All of oregano is a great product. However, you have to be mindful that it's going to also kill your good bacteria. It doesn't, like an antibiotic, it can't discern the difference.
Right. It's powerful. Oregano is powerful.
Yeah, Thorne Research has a fabulous anti-Candida product that's really also good for vaginal health. But it's just about the diet piece and using some of these targeted nutraceuticals that are really effective.
So you believe in eliminating all forms of sugar, fruit, all forms. Okay, because some people say...
when you're getting your body, if you have, we can test, I like to use the biohealth test, the stool test, to see if Candida is an issue. And if it is, then absolutely you've got to avoid all forms of sugar. Now, after you eradicate it or bring it into healthy balance, of course not. You can have your healthy, just not in excess.
Right. Okay. So I want to also ask you about Epstein-Barr virus and what part that can play as a trigger for Hashimoto's. It's coming in more and more. People are hearing about Epstein-Barr. I went to the doctor and had my yearly test to see if anything's active. Whenever I have any thing going on, I like to test those things. What are your thoughts about that as a trigger for Hashimoto's?
Oh yeah. So Epstein-Barr is one of the 3 major stealth infections related to Hashimoto's. The other 2 are Yersinia and H. pylori. So with Epstein-Barr, we really have to make sure that they are testing the correct panel. I can't tell you how often they don't.
Right.
They need to test the active antigen.
So IgM?
No, they're all IgG, but they need to test the active antigen.
Okay.
Because there are 2 antigens, 2 IgG antigens that will be elevated our entire life, no matter what we do. They'll come down some, but they're still elevated. If you had mono as a child, it's going to be elevated forever.
Yes.
But there's one marker and it's the early active IgG antigen.
Okay.
If that particular marker is elevated above an 11, it's an active infection.
Okay.
Now, practitioners were trained to know that IgG antibodies are memory antibodies, and they're going to be there forever and ever.
Right.
So in the busyness of a practitioner's day, as they're seeing patients go in and out all day long, they say IgG elevated, no big deal. IgG elevated, no big deal. They're not looking at this early active antigen. If that's elevated, it's an active case. This happened to my husband a couple of years ago, you know, and we're sitting there going, he's like, no, that's IgG, don't worry about it. And I'm like, this is the early active antigen. And he's like, oh, you know, you're right.
Yeah. And so do you believe in natural viral protocols as well?
Well, I think you can try that. If you have Hashimoto's, probably not. I think you're just dragging out your suffering longer, honestly.
Okay. So what do you do for EBV? What is your recommended plan?
Valtrex.
Okay. Valtrex.
Mm-hmm.
So is that similar to acyclovir, and that is as an antiviral, like Zolvirax or something like that? Okay.
It is.
And does that work also for cytomegalovirus, which can also be a trigger, correct, for Hashimoto's?
It can be. I don't see that often, though.
Yeah.
It's been several years since I've seen that. It's usually Epstein-Barr reactivation that we see.
Okay. So let's talk about the similarity between gluten and the thyroid and the chemical makeup of the two, the molecular mimicry, that kind of conversation, and why it's so important not to eat gluten if you are dealing, well, I don't think anybody should eat it, but especially if you're dealing with thyroid problems. Yeah,
thyroid or any pain syndrome or anything like that. It does play a role in molecular mimicry, and it's because it's a protein. I always tell people Jesus was gluten-free because there was no such thing as gluten back then. So this is a man-made thing. But what it does is, under a microscope, like in a lab, it looks a lot like thyroid cells molecularly. It really does. And so if you're talking about a confused immune system that's lost self-tolerance, and you've got leaky gut syndrome and these proteins spilling out into the bloodstream, it's not that they're ending up in the toilet, it's that our intestines protect us from the outside world, versus inside and what should be in our bloodstream and not. And these junctions, these leaky junctions, they become leaky where they're supposed to be tight in the GI tract.
Right.
Gluten leaks out into the bloodstream. As those antibodies are attacking, your thyroid, then they're crossing over and attacking the gluten. One exposure, here's what I get a lot. Oh, celiac disease is the worst case scenario for avoiding gluten, and that is not true. That's not true at all. They can actually have a percentage of gluten and still not be affected because it's not the same process. But anyway, as they spill out and as gluten's in the bloodstream, gluten is attacking that. It's crossing over, attacking your thyroid. And one exposure can elevate your antibodies for 9 months. Just one exposure. Now, patients will say, can I have just a little bit? It's not the amount. It's the exposure.
Yes. One breadcrumb or one birthday cake. Eat the cake.
The immune system does not know the difference between one molecule or 1 million molecules.
Yes.
They're acting as soldiers, okay? And they're seeing it as an enemy to be attacked.
I love hearing that. And that's something I teach too. It's what I always say when my clients have said to me, it was just one bite. I'm like, well, you should have eaten the whole thing. At least you would have gotten some pleasure out of it because it's the same response in the body, right?
Yeah, it's inflammation, and it's been proven. Like, okay, so patients will say, I just don't feel it happening. I don't have any digestive issues. Well, can you feel what your antibodies are doing? Like, can you feel what your TPO antibodies are doing? Of course not. You can't feel inflammatory markers either.
Right.
when it gets to the point you're actually feeling like joint pain and headaches and foggy brain from the gluten, that's when it's really significant. And, gluten can actually embed itself in your GI tract. It's really like glue, like the glue that's on the back of an envelope. That's how it sort of plays out in your digestive tract.
Oh my goodness. So what are your best tips for cleaning out all of that besides removing the offenders? Because, Dr. Ellen Christensen, maybe it wasn't him, maybe it was Tom O'Brien. Somebody came out with that digestive enzyme that goes in and they sell it as it chews up the gluten if you get exposed. And I'm like, I don't know and so then people are now going out, and I've seen this is,
I know.
They're eating it and then they're taking that and thinking, well, it's not affecting me. I'm like, I'm not touching it. So what are your thoughts about that? Is that even possible? Yeah.
Well, first of all, why do you want something to break it down and have it be digested? It's still the molecule is still the molecule. It doesn't change the molecule structure. I think that's just good marketing, and maybe it's good for people who they don't have an autoimmune condition or an inflammatory condition, and I can't really answer that question.
Yeah. I always wondered about it. I always, the Glutenza, I think is what the name was, one of them. I saw, that stuff flew off the shelves and it was on back order in a matter of hours when that product came out. And I had clients asking me about it. And I said, you got to wonder why you feel like you need to eat that so badly that you would spend $50 on a bottle of pills just to eat it.
Well, here's the thing. So when you eat gluten, it's not digesting of it that's a problem.
Right.
It's that you have leaky gut if you have an autoimmune condition, and there's no way that you can't have leaky gut if you have an autoimmune condition.
Right.
Digestion is not, breaking it down faster with that enzyme is not going to do anything.
Exactly.
In term, as it relates to an autoimmune condition.
Right. Yeah, I always
the best remedy for if you have been accidentally exposed to gluten is to do activated charcoal.
Yay! I do that when I've eaten and I'm like, oh my gosh, what did that have in it? I always have it in my purse. I carry that. So you're a believer in that, carrying it out?
Yeah. Yes, always. If I eat out, regardless of what it is, I don't care if I've reamed the chef up one side down the other. I take activated charcoal.
That's me too. It's always part of my life. Actually, my son came home with a stomach ache yesterday, and I was like, "What did you eat at school today?" And he was like, "It was a dum-dum sucker, but I swear that's all I had." And I'm like, "Did you look and see if it was gluten-free still?" And he's like, "I couldn't use my phone." I'm like, "Take some charcoal." There's nobody in my house eats gluten, so anytime there's any kind of a stomach upset, you either think virus, someone threw up in school, or you got into something you shouldn't have, right? Yeah. So, okay. So if people want to, I know that I have a lot of students and people that are in my Clarity course. So a little bit of an announcement, my students already know this, but I'm opening up a mentorship and mastery group. And within that group, I'm going to be putting this video in there. And many of those people that are joining and already members are dealing with their own thyroid problems. Mm-hmm. So let's just say somebody they're just tired of trying to figure it out on their own. And tell us how we can work with you. How can they work with you? How does that work? What are your suggestions?
Well, first, let me tell you that everyone I work with, for the most part, has been through so many doctors, and they're just tired. They don't know what to do. Maybe they saw me on a summit, or I don't know what, but something I said resonated with them, and I shared my story, and it can be an issue of trust. Do I trust one more practitioner type person?
Right.
But I really do go deep in working with women. They can reach me through the website, through Holistic Thyroid Care. Schedule an appointment through there, my online calendar.
Okay. Now, would you recommend they go to and take that your course online first?
Yes. I actually do prefer that, and this is how a lot of them find me, is that they went through the course and they're ready to work one-on-one. So the Hashi Sisters Autoimmune and Thyroid course You can't miss it on the homepage. It's right in your face.
Wonderful.
It's free.
Okay.
So, and it takes you through all of the, it's helpful for a patient to understand what I'm talking about as we're going through the processes, you know, and calls together.
Yeah. Okay. So here's what I'm going to do, because I do this for every expert. I create a file. And what I'm going to do is I'm going to put all of your information there for easy linking to you and learning more about what you do. And then the replay will be in there as well. So the people that were here today and the people that could not attend, because there's 55 students, and most of the time we get anywhere between 6 and 15 that are actually able to attend during the day. But then you're going to live forever in the Evergreen course, which is open enrollment. So I know this is going to be really helpful for so many people. But I also know that it's really powerful to have someone like you that you can put in your toolbox for getting through these things. Someone who can actually take the reins and tell you, this is what's going on and this is how I can help you move through this. So I just applaud your work and really appreciate your time today. Yeah.
Thanks, thank you, Carmen, for having me. And I love what you're doing. It's very important. I love health coaches, and they, you know, you all can play a huge role. You do play a huge role in helping patients navigate, you know, their health journey.
Yeah, I agree. It's good to hear that from somebody like you, for sure. So if I'm ever in Nashville, I will get in touch with you before. Maybe we can have lunch or something.
Sounds good.
All right. Thank you so much again. I appreciate it.
Thank you, Carmen.
Bye. Have a great rest of the day. Thank you. Bye, guys.